Hi, I'm Dr. Rajan Segar from the University of California, Los Angeles. The question in front of us today is, what are the acceptable goals for treating the hard-to-treat connective tissue disease pulmonary arterial hypertension patient? So I think the first message is that when we meet these patients in the clinic, it's really important to look back at what the temporal progression of disease has been for that particular patient, assessing for stability or whether there's been clear progression. And then, as important, is to look forward in terms of subsequent clinic visits, in terms of how we continue to risk stratify at each clinic visit to determine the best therapeutic options for these difficult to treat patients. In 2017, as we stand here, or 2018, the goal of treatment for the Group 1 PAH patient is to reach normal functional capacity. And it appears very clear from the available literature that upfront combination therapy appears to be the best course of action. In front of you here is a graph which is illustrating the clinical course in time in the x-axis and looking at the treatment goals on the y-axis of a functional class 3 patient. And you can see the variable interventions over time that may occur during normal clinical practice. The concept here is that the goal is to obtain functional class 1 status. And this is the New York Heart Association functional class, or the World Health Organization functional class of symptomatology, which is well known to all of us and similar in the left heart failure world. So again, our goal is to reach functional class 1 symptomatology, and at this stage of where we are in pulmonary hypertension specific therapies, upfront combination therapy appears to be the optimal approach, particularly for patients with Group 1 pulmonary arterial hypertension related to systemic sclerosis. So again, to continue to highlight a theme in terms of goals, our goal is to, again, normalize patients and not to just preserve or slightly improve their functionality. If you look at this graph here, you can see the features that we are trying to obtain in our patients in terms of creating or reaching for low-risk status. And these risk profiles are really estimating 1-year mortality and can be differentiated based on several parameters. And you can see those on the left, which include clinical signs of right heart failure. So this is your clinical exam in the clinic, trajectory of symptoms or progression of symptoms, the presence or absence of syncope as a presenting feature or a feature over time, the functional class of the patient, the 6-minute walk distance, features on cardiopulmonary exercise testing, NT-proBNP or BNP assessments, which are, of course, blood tests, echocardiography, or in some cases, MRI, cardiac MRI, and finally, right heart catheterization-related hemodynamics. And based on these assessments, not all of which have to be done at every clinic visit, of course, we can make assessments of low risk, intermediate risk, or high risk. So again, to answer the question, our goal is to create normalization, functional class 1 symptomatology in these very difficult to treat systemic sclerosis or autoimmune disease-driven pulmonary arterial hypertension patients. Thank you.